This is the Situation Room, the only way to start your day.
Mvua Boga, she's here from Kemri Welcome, and we're going to be looking into treating fragile lives with respect, and we'll get to know a little bit about what that is all about this morning. Mvua, good morning.
Morning to you. How are you?
Very well, thank you. Karibu sana.
Asante sana.
In Nairobi, or have come from outside Nairobi?
I've come from Mombasa.
You've come from Mombasa?
Yeah.
All right. Of course, we know some of the work that happens with Kemri Welcome around those areas, and so we'll be looking into some of that this morning.
Yeah.
Let's welcome you to the hot seat of the Situation Room with today's proverb. Dennis will tell you what that's about and where it's from, and we'd love to hear your interpretation.
Okay. You know, I'm quite surprised you pronounce that name. I was waiting.
You're waiting for me to mess up.
Yeah. You know Mvua, what it means?
The one who brings rain.
Oh, you do? You know. Mvua. Oh, boy. Is it?
Yeah.
Is it true?
Yeah.
Thank you.
So Mvua ni mtoto wa mvua.
Kitu kama hicho.
Ama ulizaliwa kati kulikuwa na mvua.
No, hilo ni jina la nyanyangu ulipewa.
But lamaanisha nini?
Ni umezaliwa wakati wa mvua.
Wakati wa mvua, season ya mvua.
Kitu kama hicho.
Okay. I'm going to the coast.
Lakini mnaweza niita tu mwana. Hilo ndo jina many people.
Mwana.
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 Mwana. Let me write that one down before I go to the proverb.
I hope your proverb is not hard.
Oh, don't worry.
Well, it's a very simple one. We are in the country called Egypt.
Egypt, yeah.
North Africa. So in Egypt, they were known as the ancient men and women of wisdom. Because they influenced a lot of what we call today civilization. So the proverb that is we are dealing with today is oh gosh, where is it? Now that you said you hope it's not a difficult one.
I'll give you one from
You will
my
give me one.
If you can't find yours.
No. Trust in God, but tie your camel.
Yeah.
That's the proverb.
Yeah.
How would you interpret that?
In fact, that's it's also part of the Islamic culture.
Okay.
That tawakkul, meaning trust in God, but tie your camel. So put trust in God, but work hard on whatever you're doing. Not just saying God will make it for me without putting any effort. That's what it means.
Like God will provide, and then you're not working.
Yes.
You have to go work.
Yeah. So you pray, but you also work hard.
Oh. Okay.
Exactly. Yeah.
What Swahili? What's the equivalent in Swahili? I'm just trying to think. Because the ones I have in my mind, like I said in the morning, one is from the Bible also. Faith without works is dead.
Yeah, exactly.
So you must practice what you believe in.
Yeah, exactly.
What's Kiswahili itakuja baadaye. Yes.
All right, and even as we get into this conversation, Mvua, we are looking into, I'll just call him Mwana.
Yeah, you say call me Mwana.
All right. We go that way. The power of words and emotions in newborn care. Some of us don't even imagine that that's a thing. Start us off from the premise of why this is important and why this is even an approach or in the very first place.
Yeah, that's a very important question. And I'm very happy to be in this studio today to share exactly the kind of work that we do, the challenges we face on the front line. And I want to start this conversation with a story from my practical work experience on how we handle these mothers and what kind of patients we get on a daily basis. So this is a mother who is pregnant. She's 9 months pregnant. She's in the rural village, and she gets into labor. And then she goes into the dispensary, which is the nearest health center for her to give birth. So she goes in there. The labor complicates. She's not able to get her baby normally. And she has to be transferred to the level 4 hospital for cesarean section. There are no ambulances at the dispensary level, so an ambulance has to be dispatched from the level 4 hospital to the dispensary to pick this mother to come for cesarean section in level 4 hospital. So the ambulance takes like 2 hours to go pick this mother who is in labor, and it's obstructed. So she comes into the level 4 hospital after 2 hours of delay. When she gets into the hospital, there is another mother in theater who is going through cesarean section. So this mother has to wait again before the operation is done. So she gets into the operation room after maybe another 30 minutes or 1 hour of waiting. And the baby is in there and they're stuck. So she gets into theater And eventually the operation is done, but the baby is very tired. So we call that birth asphyxia. So the baby comes out, but he's not able to cry because he's very distressed because of the delay that has happened. So this baby ends up in the newborn unit where we care for them. So you have a mother who has had a cesarean section, a baby who is critically ill, and then you're faced with the parents there. The father is there. So this is a real case that I handled recently. So the father is there, the baby is on oxygen. We're trying all the best we can to save this life. And I can still remember the kind of question this father was asking me. Like, sister, will my baby be okay? Please do the best you can for my baby to be okay. So I just want you to imagine the kind of emotions this parent is going through. Their joy has been turned upside down. For 9 months, the kind of, when you're expecting a baby, the kind of joy that it builds in you, the kind of preparation you make, and suddenly the ending is like that. So parents go through a lot of emotions, and that's why communication comes in very handy, because you need to allay the anxieties, you need to allay their fears, you need to give them hope where there is. So that's how the kind of emotions, very raw, very painful emotions that we face on a daily basis. And it's not just one. You can have like those kind of cases like 2, 3 in a day.
Yes.
So our interpersonal skills play a very crucial role to allay patients' anxieties. And most of these parents, sometimes they stay in the unit for a while. So also we need to work with them together as partners, so strengthening patient-centered care and also communication. It also strengthens patient satisfaction. When you look at most of the patients' complaints on the care we give, it's all about how they were related to, how we talked to them, not about how the drugs we gave them or how we dressed their wounds, but how we talked to them. So communication is the core of our work. Before you diagnose this patient, you have to talk to them. Before you treat them, you have to talk to them. So it's really core. And it doesn't just help the patient. It also helps us as carers for these mothers and families. Because when you talk to them well, they're able to cooperate in the care you give.
Okay. And sorry, but just as you say that, how does it help a caregiver if you are speaking to a patient and if they then open up? How does that help in the medical process of things? If they open up and then are comfortable with a caregiver, how does that then make it easier for you or any other caregiver to do their job? And caregiver here, we're talking about across the medical sphere, doctors, nurses, those who deal with it or across board. How does it help if I'm opening up to you?
It helps a great deal, because often, you can just imagine yourself before you see a doctor, if you've had that kind of an interaction. Just before you go in there, you're really anxious because you don't know what kind of a person you're going to meet and how the reception would be. So if you are, your personal skills as a doctor, as a nurse, plays a key role here. Because this is somebody who has come, they have issues, they need to open. Sometimes they have very sensitive issues. And if the interaction is not kind enough, or there is no empathy, they may not even open up and tell you the exact problems that they have. So when the communication is when you are first, how you meet this patient matters a lot, because it helps them to open up deeper and share their issues. And then you as a clinician, or you as a nurse, you're able to elicit the exact issues that this patient has come in with, and you'll be able to make the correct diagnosis for them through their clinical.
Is it part of training? And I'm asking this question because it seems as though, if so, there are a number of medical practitioners and caregivers who must have been absent on that day when that part of the course was taught.
That's a very interesting one.
Yeah, is it? Because I just think about a couple of weeks ago when I took my daughter to hospital, and we walked in to see the specialist. The man didn't even bother to look at us. He had his back to us, and he just looked at the results from the scan or whatever it was, and already started talking. Didn't even bother to look at who this person is that was under the lights of the scan. Didn't bother, just continued. And I took an affront to it, and I said, you know what? We are here. You're going to have to look at us First of all, you need to know the person that you're speaking to. You've assumed that there was nothing wrong. We ended up doing a procedure that solved the problem because of the insistence that what you are saying you see is not what we are. You need to acknowledge that we are even here. Don't go through it like you're going through a list. So that's what I'm asking. Are people trained, or do they just want to get through the day?
And that's a very important. I'm very sorry about your experience, but that's a very important question. So communication really, it's not taught as much as we would want it to be taught. For example, if I take my own experience as a nurse, I learned communication in the first year of nursing school, and I was around 18. And you learn it before even you meet the real patients. Okay, and it's very small and very theoretical in nature. It doesn't link to the realities of practice. So it's taught but very little. And that is what you need to go with as a nurse for 30 years, 40 years of experience. So it's not given the right attention that it needs to be. Just like the way we are learning the technical skills of our profession, the soft skills needs to be given that very attention. So they are not taught as we would want them to be taught. And then so this little that you are taught in the nursing school, when you come into the practical areas or the clinical areas, you meet mentors who will influence the way you do things.
Yeah.
Because you meet them and they're burnt out and they talk the way they talk, and that's what usually carries the day with you. So this is an area that we really need to pay attention, because it makes such a difference in the care we give to our patients. Patients will remember you for who you are as a person, how you made them feel, but not even how the drugs that you gave them, but how you made them feel.
There are arguments that might sound ignorant from my end, because I'm surrounded in the studio by two mothers. And these conversations, I will just draw from things that I hear, things I've observed. So for the longest time, for example, there's a maternity hospital in this city. And every time at the mention of that hospital, what comes to mind is ile matusi natokanga kwa nurses when mothers are going to deliver. And the experiences of women who've gone there and the stories they come up with, horrible stories of how they're treated and how they're handled. And they're in this very delicate stage, like you're saying. It's a beautiful thing. A woman is carrying a baby for 9 months. The excitement at seeing this baby once you've delivered, it's something else you can't even describe. But that journey and the experience is like the nurses were just wicked in nature. And the counter argument is, no, their language and their communication is just meant to toughen you up, because there are some who come, they're like they're about to break, and they're told, woman up.
You can actually do this.
You can actually do this, but the tone and the language. Yesterday, you're sitting where a father sat, and his son-in-law was sitting across there, and we were looking at a case, and it was a very, very sad case, where the father lost his daughter when they went to this hospital, and the daughter, 26 years old, the pregnancy was good, she was of good health, and she was going in for delivery. The whole thing ended up to be a botched surgery. The baby survived, but the mother died. But how they call them sisters, the nurses handled the family in that loss is they were taken to a room, and the family is demanding, tell us what's going on, and they're not getting answers. And the response they were getting, the communication again is atuongei na watu wenye asiwezi ongea na mtu akona hasira, kaeni chini. So listening to the conversations, you can clearly tell what they remember during that traumatic experience is how the tone and the communication that was coming from the nurses in passing on this message. And you're saying this is not very well taught in schools. My question is, why? Is the syllabus created in a way where you're thinking medical, but you're also not thinking interpersonal skills, you're not thinking communication, the whole spectrum? Why is there that gap?
Okay, that's in fact, sorry for that very unfortunate story about this father. I don't want to defend the nurses, or these things happen, and they're all over, as you're saying. Yes. But often when you see the nurses behaving this way to mothers, it's it's unacceptable. Okay, it's an unacceptable behavior, and often these behaviors are driven by fear. By fear. Often they want this mother, their intention is very good behind there. They want the mother to have a very live baby and go home with a live baby. But the approach, as you say, is what is a problem. But they have very good intention. They want the mother to deliver, have a baby, go home. Because even when we lose a baby, it's you have to write statements, what happened, explain everything. So the nurses also don't want that to happen to them. So their behavior is driven by fear and they're not knowing how to handle mothers better in a respectful way. And there are many efforts.
Somebody tells you, mimi sikuwa wakati ulipata mimba. How does that come from a place of fear?
So as I said, those interactions are very, they are disrespectful in nature. And there's a lot of literature around disrespectful care, and a lot of efforts to promote respectful maternal and newborn care. There are a lot of efforts to promote that. So I think what we are saying is these skills, there's a gap, and we need to address it as a healthcare professional, as leaders. We need to we need to address this gap. So I totally acknowledge that this gap is there, it's documented.
Yeah.
So it's time that we need to address it. But also, some of the drivers to these behaviors is the kind of work or environment these nurses work in. A very busy environment. You may be alone in the maternity, and you have like 5 mothers to handle. So sometimes it can get extremely overwhelming. So burnout also does contribute to how we behave sometimes. So burnout, you are working in environments where you have resource constraints. You want this is not there. You want this is not there. You've been at work. Maybe you've not even taken your leave from some nurses. They go for months, for years. I mean, without taking their leave. So burnout really does contribute to these behaviors. But all in all, we are saying they are unacceptable behaviors, and something needs to be. We need to rise up.
Sure. Unfortunately, the bulk of this blame has been put at the foot of nurses. But, just like I told you, and I was starting to see a little bit more, is that other medical practitioners now getting to the point where it could be busy. It could be that, yes. But by the time somebody is coming to you in hospital, it's not that they were bored and didn't have anywhere to go. This person is unwell. This person, there is a concern. And by virtue of the fact that a medical practitioner is on the other side means that they can diagnose what is wrong. And I assume that those things are taken into consideration. Do we see misdiagnoses sometimes from not opening up to your patient, or from not giving your patient the conducive environment in which they can then open up? Or do we sometimes say, well, there's nothing wrong with you, I've looked at this, there's nothing, just go away, which has been done before? Do we see that misdiagnosis is a threat because of this lack of communication and openness?
Yes. There is a lot of literature, and documented literature on medical errors as even misdiagnosis, just because of the communication wasn't as good as it was supposed to be. And I can give you an example. Sometimes when you talk through an example, it makes a lot of sense. So we had a grandmother who brought her child to the hospital, and this child had a skin infection, and was put on some antiseptic, a lotion just to bathe the child. Yeah. But the way the instructions were given, it wasn't very clear to the grandmother, and I think so. She was told he utatumia mara mbili, see, and it's liquid. So this grandmother, her understanding was you will give the child orally. So went home and gave it orally, and within no time the child was brought back to the hospital unwell. So these things do happen. So it's very important when we are relating to our patients to make sure that they have understood what we want them to understand, because often patients are clouded with fear, with worries. So you need to be patient with them when you're talking to them. Be patient with them. Make sure that whatever information you've given them, they've really understood. Yeah, so it does happen.
Let's talk about eye care, Holland model.
Yeah.
Eye care Holland model.
Yes.
What is this exactly?
That's a very interesting one. So this is a training initiative that I've been running to strengthen health workers' skills to communicate with respect to patients, to colleagues, and to manage the many emotional challenges that the things that we are talking about, and the gaps that we are acknowledging that there's a gap in terms of skill. So this is a training that I've been working on for the last 10 years or so within the Cambry where I work. So this training is a process training. It's 6 to 9 months of training. And many people ask me, why are you training people 6 to 9 months of communication? Okay. And we're saying the habits we have today, these are entrenched deep down in us. And you can't change a habit within a day or two.
True.
You can just create awareness, but you cannot change the way somebody communicates in a 2 or 3 day session. So this training is a process over 6 to 9 months, and we've divided it into phases. So we have a phase 1, which is a 2-3 months of self-observation and reflection. So we support the nurses or the health workers with reflective assignments to reflect over their own behaviors in practice and see the effect of their communication on patients real time. So an example of a task we give them is, how well do you listen to your patients? The exact thing that she was talking about, that this doctor did not even listen to her. So we ask them for 1 week, just look at how are you listening to your patients? When you listen well, what happens? When you don't listen well, what happens? And then another thing is, another task we also give them is understanding of their emotions and how they react to situations. So look at a week time, look at what are the things that irritate you when you're working with patients, with colleagues. And when you are irritated, how does that affect the way you relate to the patients? So these reflective assignments, they are meant to build their self-awareness in a safe way. Because it makes a difference when I come to tell you that, you are not a good listener. You will run into the defense. But we give them safe space to look at their own behaviors. And then after they have looked at their own behaviors, we ask them to write for us their observations, their narratives of the situations they have discovered about themselves. What are they doing well? What are the areas that are struggling with? And then we read these narratives. From their narratives, we create role plays, we create skits, we create dramas. And then we now invite them for a workshop, which is a face-to-face workshop. So this reflection period is to help them build that self-awareness. So by the time they're coming for the workshop, they know exactly what their struggles are with patients. So the training is a 3-day training, and it's tailored to address these exact problems that we are talking about here. This nurse shouting at a mother who is in labor. So we make skits of a nurse shouting at a mother who is in labor. And then we say, okay, let's step back. So do we do this to our patients? So they get to acknowledge, yes, this does happen. Why do we do this? 1, 2, 3. They say the kind of things that drives them to these behaviors. Are they justified? So we get to really reflect on our own behaviors in a safe space, because it's us discussing, and the aim is for us to improve the way we handle patients. So in these workshops, we address the realities of practice, not learning things theoretically. No, the kind of situation you shared where the doctor did not look at you, that is exactly what we will play out in the workshop, where a patient has come and you're busy on your phone or doing something
just
else.
Writing.
Say,
not even come.
Let's step back. How does this feel? How do you think the patient felt? So they get to see that the things we do sometimes they are not so good to our patients.
Okay,
Yeah.
let's take a break at this point. We're talking this morning around the issues of how actually patients are handled, or, I like that you call it fragile lives, treating fragile lives with respect, the power of words and emotions in newborn care. Let's come and zero in on newborn care when we come back from this short break. Mwanamvua Boga is with Kemri Welcome, and she's here with us this morning as we have this conversation around these particular areas. We'll be back after this in just a short while. Don't go away. It is 25 minutes to 10.
This is the Situation Room.
Healthcare, improved diagnosis, improved communication from these trainings in terms of numbers now. After the trainings have taken place, do you see that, okay, we are hearing less complaints? We are seeing that we have an improved healthcare procedural way of doing things?
That's a very important question. Maybe just I talk about how we evaluate this training so far, because we have not reached a critical mass where we also look at patient outcomes. But for the last 6 years, we've been working closely with the newborn nurse managers to scale up this training to newborn units, where to strengthen our respectful care in our newborn units. So how we have been evaluating it so far is to look at reported changes by the health workers themselves. What are they saying they are doing different after the training? So before they join the training, we usually give them a questionnaire, a tool to assess themselves on their strength and weakness around communication. And then at the end of the training process, we also give them another tool to assess themselves and document any changes that at a personal level. But also we track these reflective assignments. We track them to see are there any changes we are seeing in the way they are handling patients differently. And also another way we also assess whether there is an impact is by interviewing managers who are working with these people who have been trained, their colleagues who have... the colleagues who are working with these people who have been trained, we also interviewed them in some selected hospital. And yes, they say they see that their colleagues they've changed the way they treat patients. So the changes are there, but are reported, and we have not looked at patients' outcomes. And some of the changes that the health workers themselves are reporting that we are doing things differently. One of the major changes is that increased self-awareness. Being aware of your own behaviors and the way it affects others, the way it affects patients. And also learning to recognize your emotions and step back from reacting out automatically to patients and colleagues. And that's one of the key learning that majority of the participants report an improvement. And the majority of them say that they didn't know that learning to manage emotion is something that can be taught. So they are very grateful for that skill. And the way they treat patients, they're saying now they listen more to patients, despite these very difficult working conditions, but they can listen to mothers better. They see mothers as fellow human beings. Yeah, because they are part of us. And even us as healthcare workers, we go through the same things that our patients go through. We are susceptible to getting preterm babies, susceptible to getting all these cases. So we are not an exemption. So now they are treating mothers as fellow human beings, not just seeing the disease, but also holistically, what does this mother bring when she's in the newborn unit? What more is behind that is influencing the way she is? So those are some of the changes that they are reporting. And then in terms of how they are working with colleagues, because the communication is not just the patients, it's also about how we relate with each other at work. So they are saying there's improved the team relations, better appreciating one another. Sometimes we work with each other and even saying thank you, even saying well done for something that they have done. We don't do that, and it can be very demotivating. So we are working in these very difficult spaces. So we need to empathize with each other, not just the patient, but among ourselves, we need to empathize with one another, appreciate the kind of work that we do to each other so that we lift ourselves up and be able to survive in this space for the next 30, 40 years of your career. So those are some of the changes that they are reporting. But as I say, looking at patient outcomes themselves, we've not done that. But we have also, there's some piece of research where we've looked at these, the health workers that we've trained, we've observed them in their work practice. to see what are they doing apart from the reported changes. Are we observing any good interactions with patients in their daily practice? So that's something that we've also looked at, and we are seeing some improvement.
Yeah.
Not everyone would change through this process because change is a personal. I may train you, but at the end of the day, you need to be willing to take that personal initiative to wanting to change. Change is very personal.
You know, there's I want to bring in an element here, and there's always an argument. You know, if you meet a nurse, or you go to hospital, you can clearly tell this is a nurse by the mannerisms, how they talk. They sound polite as you, very soft-spoken. And the people,
thank you for the compliment.
and the people who normally say, kuna watu hawezi kuwa nurse. Yes, you ulisomea, but your character, the people are just not empathetic naturally. You can't train that. They're just not there. And they are loud, for example. They can't read the room. There's an element of emotional intelligence and situational awareness that to some degree you cannot even train this person. And I'm saying this because there's an example I have I've just remembered. And the question is, where silence sometimes can speak louder than words. I've been in a situation where there's a nurse, ameongea sana. They can't tell that the environment now is becoming uncomfortable. You need to go. But their story up on another story and another, and they're just trying to be in their communication. They overdo it. They're talking too much. My question is how should then nurses balance silence, listening, and speaking? Is that part of the lessons they learn? Because there are places you go to, like I said, where it's being overdone. You find this person is talking too much, and they don't read the room that this person needs to rest. The mother needs to. You need to go.
And that's where the self-reflection comes in. Often you may find somebody behaving that way, but they are not aware that
they're behaving
that way, and that their behavior is affecting other people. So when you give them time to reflect and sincerely reflect, then these are some of the things that they should be able to pick on themselves. But so these are the skills that we teach in the training. We teach them how to listen. What is good listening? How does it look like? How do you do it? How do you ask your questions? When you have a patient, how do you ask your questions in a manner that it's palatable, it's friendly enough for the patient to open up? How do you empathize in this context of a very busy ward with 40? I mean, so you know the kind of ratios nurses, the workload is way too high. One nurse managing like 30, 20 babies alone.
At the same time,
you know. So how do you empathize? How do you empathize with these mothers in this context of where you are all alone and with this kind of workload? So we teach them the practical ways of how to do this in this very heavy work environment. Like for example, if I come in, I have to have that awareness that I have a big workload here. I have mothers to take care of. So how is your attitude? You know, patients are not looking for big things. They're just looking for your attitude around them. And you, as you say, the demeanor, the friendliness, the being approachable. So you come in, it's full, and you just say, hello, good morning, how are you? How was the
That's
night?
all it
How
takes,
are your
really.
babies?
Yeah.
How much does that take? It doesn't take much time. And already you establish rapport with them, and they will ask you anything they want to ask. So they're not big things. They're
small things.
They're small, doable things that cost, well, should I say cost nothing? Greeting a mother, greeting a patient, smiling at them, it doesn't cost.
So
it makes that difference.
So it seems to me there's a way the program is patient-centric.
Yes.
And the focus is really the mother, the baby, and all that.
And the health worker.
And the health worker as
Yes,
well.
yes.
Now that you mentioned the health worker, my concern is where we are today as a country, for example. in terms of emotional well-being, we've had nurses who've actually ended up ending their own lives because of stress from work and so on and so forth. In terms of emotional well-being, you'll find, just as everybody else will walk around with trauma, nurses also carry trauma themselves.
A lot.
It could be they also have a patient somewhere sick in a hospital. It could be family issues, domestic issues. It could be issues to do with salaries. They've not been paid. Working long hours, handling, like you're saying, 20 babies. That is 20 mothers. So that's 40 patients that you're handling. How does the training then help them manage their own stress and trauma and avoid passing it on to the mother or to the parents around? Because you'll often see some people, there's an outburst, you can tell this is coming from somewhere. It has nothing to do with me or what you've just seen. You're coming with your own stress.
Exactly.
Stress yako na pressure yako. So how then, how does the training then help them cope with all those things?
So that's a very important question. So one of the modules we cover in the training is stress and burnout. Okay, stress and burnout, how to recognize your own stresses, how to recognize stress. You know, many of us walk, as you say, we're stressed, but we are not aware. We are not aware that we are stressed.
Niko
sawa tu, and we are not aware. So we raise awareness about stress and burnout. The telltale signs that you're stressed, telltale signs that you're burnout, and what then you can do for yourself. So we also stress a lot on self-care, how to care for your own self as a nurse. Not just a matter of caring for patients, but also caring for our own selves. And we discuss about the strategies of how to take care of yourself. And these are things that they should be within your reach.
But truth be told, humanly speaking, you talk about, coming in and saying, and I get it, because you can shift it. Even like the stuff that we do here in the morning, sometimes you're just not feeling up to it. And to come in and give a smile and say good morning when you're dealing with people, how do you, because you talk about the training that you do, but practically, Mona, how do you do that? The world could be falling apart for you, but you have to come and put a smile on your face and be as real as possible. And care for somebody. It doesn't take away from the element of humanity, the thing that you're going through, for sure. But to then be able to keep up those graces may not be easy sometimes, looking at it. So how do you do it? How do you tell somebody whose world is falling apart, Mona,
I think
that you must come in the morning or on your shift and really welcome this other individual?
No, I totally agree with what you are saying. So the thing is, this training is not meant to solve all the health system issues. This is just a bit of it. But there's so many things that the health system needs to take care of. The work shortage, the resource issues, all that needs to be taken care of. So the training is a very small bit, but the health system issues needs to be addressed. Okay. And then at a personal level, as you're saying, we also encourage the health workers to seek help. Some of us are struggling with depression, struggling with mental health issues, but we are not forthcoming to go and seek help because of the stigma around mental health. So in the training, we encourage people that it's okay not to be okay as a health worker. And by the time you are breaking up, it means that you've been strong for so long, and your resilience now is just not working for you. So it's okay to seek help and get treatment. So we encourage them. So I'm saying the training will not solve everything, but it's to really empower the nurses on a better relationship with patients, their own well-being, and also, when we talk about well-being, also the ability of you to recognize that our colleague is not okay. Yeah. Many of us, sometimes we are not aware. Somebody is struggling, they're coming, and suddenly we hear so-and-so has done 1, 2, 3, and we're like, what happened? So that also being aware of, is my friend okay? Is my colleague okay? Having that sensitivity so that we can support each other better.
You could feel something, for example, and it could be truth. And I'm just pulling off a comment that we've seen, where you could see that in this particular case, there is no hope. That person is vulnerable to a point where it's it's evident that there's very little that can be done.
The patient or
For the patient, from a healthcare perspective, from medical perspective, how do you handle that, knowing full well, and as opposed to handling it for this patient without letting it out in an insensitive manner?
So dealing with death and dying, it's a very tough topic. It's a very tough situation, and that's what we deal with on a day-to-day basis. I work in a high dependence unit, caring for babies from day 1 of life to 12, and they come in very critical. And sometimes we lose them 2-3 in a shift, and it can be
In a shift?
Yes, and it can be extremely traumatic, not just for this one who is losing their baby, but even for the neighbors sharing beds, and even for us. We're human beings, at the end of the day. We are mothers, and when we see these losses, it's hard. But so in the training, so we also have a module on dealing with death and dying in a manner that is respectful. And they're difficult conversations. I wouldn't want to say that they are easy. They are very difficult. And for you to be able to handle these situations better, it comes with practice over time, handling them. But learning how to handle them is critical. How to have this conversation is very critical. But of course, you need to be very sensitive when you're handling. And you cannot, you can't just tell a parent, your child will die. No, not to that extreme of insensitivity. But always getting from their point of view, how do you see your baby? How is it? When the baby is admitted, right from the word go, you can tell how this baby is. So involving the parents right from the word go, and informing them on the progress of the care, what we are doing, and how the baby is going on, and if there are any deterioration, communicate that early enough. And that's in that way you are building that process of the outcome, whatever it will be. So you don't wait until to the end and then say, oh no, your child is very sick, they are going to die. No. You take them pole, right from admission, and walk with them in the journey to the outcome.
So, Mona, I mean, a lot of good things that are coming from a program like this, but in terms of broadening it, there's an issue of policy, for example, and adoption of some of this, because what I sometimes see is an example of what you're doing. You've got on the sidelines a very, very good program where you're taking nurses through all these things that is not just helping them in their career, but it's also helping them know about themselves. It's about behavior, it's about character, it's about empathy and all those kind of things. And I find a lot of good things in it. But what lessons, in your opinion, do you think policymakers can draw from this kind of programs when it comes to, and I know it's normally a phrase I hate using, but it's used in government circles and in programs, reforms. So, so looking at this program, what are the lessons you think can be borrowed by policymakers when it comes to reforming newborn care in Kenya? Yeah, if you're to speak to MOH, for example, or you're to speak to government, or you're speaking to a policymaker, what are the lessons that they can borrow and adopt it into now a curriculum for nursing?
Yeah, so that's a journey that we are working towards. It takes time, to build good things and getting them embedded into whatever policy. But I think one thing is to have these skills embedded in the curriculum, as you say, and change the way we teach, improve the way we teach these skills to our nurses. And it shouldn't be a one-off training. It shouldn't be a one-off. These skills should be trickled down from year one to exit. And that should not be the end. These skills should also be embedded within quality improvement initiatives. There are so many quality improvement initiatives, programs within the newborn care unit. And we are working to negotiate to see how some of these modules could be embedded within the quality improvement initiative so that there is that continued continued learning across different
Yeah.
initiatives, because these soft skills, they also need to be nurtured. You know, with time they rust, so they need to be.
There needs to be constant,
constant.
reminding rather.